Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular session, I'll be discussing the quiz which I have posted on 20th of May on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So every day I'm posting the quiz, and on subsequent day I'm sending the explanation as well. So join my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, for daily quiz discussion. So as a part of it, the first question is, today's questions are mostly on one question on the motor neuron disease, and the remaining four questions are on the topic of the neuromuscular junction disorders, that is myasthenia gravis and Lambert-Eaton myasthenic syndrome. So let us discuss them. So all of the following are the features of amyotrophic lateral sclerosis, except more common in male than females, death of posterior horn cell neurons, death of neurons in motor cortex in cerebral hemisphere, bladder is not involved. So if you see in amyotrophic lateral sclerosis, this is the most common cause of the motor neuron disease. And in these patients with amyotrophic lateral sclerosis, there is involvement of both upper motor neuron and as well as the lower motor neuron as well, right? And in these patients with amyotrophic lateral sclerosis, it is more common in males rather than females. And these patients in ALS, they will not have the death of the posterior horn cell, it is the death of the anterior horn cell. And because of the involvement of the anterior horn cell, the individual will have lower motor neuron manifestations, and the pathognomic features will be in the form of the fasciculations. So these are the features due to the involvement of the anterior horn cell. And there is also death of neurons in motor cortex in cerebral hemisphere, and that will be responsible for the upper motor neuron manifestations. And bladder is not involved in patients with amyotrophic lateral sclerosis. And what are the drugs that you give in the treatment of amyotrophic lateral sclerosis is, we have one particular drug called riluzole, and the another important drug is edaravone. So these two drugs, right, they will prevent the progression of the amyotrophic lateral sclerosis. So this is about one question on the ALS, and the remaining four questions are on the topic of the neuromuscular junction disorder, that is myasthenia gravis, and as well as the Lambert-Eaton myasthenic syndrome. The following are true about the treatment of myasthenia gravis. Thymectomy is indicated in the absence of thymoma. Routine use of glucocorticoids is not indicated. Immunosuppressants like azathioprine are used only in myasthenia gravis. MuSK antibody positive go into complete remission with thymectomy. So in the treatment of myasthenia gravis, you have to understand that thymectomy is being done whether the thymoma is present or whether the thymoma is not present. So thymectomy is indicated definitely. But only thing is, it has to be done in the age group between 15 to 55 years of age. And what is the drug of choice in patients with myasthenia gravis? So in moderate to severe form of myasthenia gravis, the drug of choice will be the steroids. Right, the drug of choice will be steroids. So routine use of glucocorticoids not indicated, that is a false statement. And you take the third option, immunosuppressant like azathioprine are used only in myasthenic crisis. So in case of myasthenic crisis, you need to understand that the drug of choice or the treatment will be the IVIG, that is intravenous immunoglobulin, or you need to do plasmapheresis. These are the two treatment options for myasthenic crisis. When do you give azathioprine is, you give azathioprine when the individual is refractory to steroids. That is the point when we give this azathioprine, right? Now, MuSK positive patients go into complete remission with thymectomy. So first of all, you need to understand that MuSK positive myasthenia gravis, right, thymectomy should not be done. Right, thymectomy should not be done in case of MuSK positive myasthenia gravis. Now let me tell you in which scenarios you need to do thymectomy and in which scenarios thymectomy should not be done. So this table is very important. So thymectomy, it is being preferred in individuals between 15 to 55 years, and all patients who have thymoma, they have to undergo thymectomy. And even in the absence of thymoma also, thymectomy has to be done. And children less than 15 years and elderly more than 55 years, thymectomy is usually not done. And myasthenia gravis limited to extraocular muscles. That means ocular myasthenia gravis, thymectomy is not required. And patients with MuSK antibody positive also, thymectomy is usually not done. So this is about the treatment in patients with the myasthenia gravis. The drug of choice will be steroids, whereas in mild myasthenia gravis, right, the drug that we give is pyridostigmine or physostigmine, or we give neostigmine. Okay, that is in mild myasthenia gravis, whereas moderate to severe form of myasthenia gravis, definitely we give steroids. Now, you see the next question. All of the clinical features of myasthenia gravis except asymmetrical ptosis, absent deep tendon reflexes, proximal muscle involvement, worsened by exertion. So, in myasthenia gravis, the earliest manifestation that you come across in patients is the asymmetrical ptosis. And how will be the deep tendon reflexes? Remember, the deep tendon reflexes will not be absent. The deep tendon reflexes will be intact in patients with the myasthenia gravis. And yes, proximal muscle involvement is more common than compared to that of the distal muscle involvement in patients with the myasthenia gravis. And these clinical features of myasthenia gravis, they worsen by exertion. That is also a true statement. So which is the incorrect statement? Except absent of deep tendon reflexes is the incorrect statement. Now, apart from the muscles of the eye, that is extraocular muscles or levator palpebrae superioris muscles, the other muscles which are being affected is the muscles of mastication. The individual will have difficulty in mastication, right? And the individual will also have difficulty in swallowing because of the involvement of the pharyngeal muscles. And the muscles of mastication are being weak. That is the reason why the jaw, it sags down, and these patients, they also have difficulty in chewing. So these are the features of the myasthenia gravis. And apart from that, the proximal muscles are the one which are more commonly affected than distal muscles. And even the neck muscles, the flexors and as well as the extensors of the neck are being affected in patients with the myasthenia gravis, right? And deep tendon reflexes, they remain intact. Only in advanced stages of the myasthenia gravis, there will be involvement of the respiratory muscles as well. So once there is involvement of the respiratory muscles, the patient will develop type 2 respiratory failure. So these are the features of the myasthenia gravis. And we have a form called as the ocular myasthenia gravis. In ocular myasthenia gravis, it is characterized by a triad. What is a triad of ocular myasthenia gravis? There will be ptosis, and that is due to the involvement of or due to pathology in the levator palpebrae superioris, diplopia, and orbicularis oculi weakness. So this will be the triad of ocular myasthenia gravis. And what will be the investigation of choice in case of ocular myasthenia gravis is that the antibodies, that is the anti-MuSK antibodies, are being positive. And what is the drug of choice? The drug of choice will be the prednisolone. Right, drug of choice will be prednisolone for ocular myasthenia gravis. So this is about the clinical features of myasthenia. Now let us discuss the investigations in myasthenia. A 35-year-old female has proximal muscle weakness and ptosis and easy fatigability. The gold standard test to confirm the diagnosis is, so the clinical picture, it is very much suggestive of the myasthenia gravis. And in myasthenia gravis, there are multiple investigations, but what is the investigation of choice? The investigation of choice will be single fiber electromyography. Among all the investigations, single fiber electromyography, it has the sensitivity of nearly around 99%. And if you take the other investigations, yes, we also do the hydrophonium test. And we also do this acetylcholine receptor antibody testing as well. So if you see this table here, right, so we do acetylcholine receptor antibody, repetitive nerve stimulation, single fiber electromyography, and hydrophonium or tensilon test. But among all these, the sensitivity, it is highest for single fiber electromyography. So the answer is single fiber electromyography. Then last question. Which of the following sentence about Lambert-Eaton myasthenic syndrome is false? Tensilon test is positive, associated with dry mouth. Antibodies are present against the presynaptic calcium channels. Incremental response with low frequency repetitive nerve stimulation. So now tensilon test, it is positive in both myasthenia gravis and as well as the Lambert-Eaton myasthenic syndrome. And these patients, they also have autonomic manifestations in the form of dry mouth. And if you take the antibodies in Lambert-Eaton myasthenic syndrome, the antibodies, they are being formed against the presynaptic calcium channels, right? Voltage gated calcium channels. So because of the antibody formation against the presynaptic calcium channels, you have to understand that the calcium will not enter into the presynaptic nerve terminal, and thereby there is no release of acetylcholine. right? There is no release of the acetylcholine, and thereby neuromuscular transmission does not occur in patients with the Lambert-Eaton myasthenic syndrome. Now, what is the right? So, what is the false statement here? Incremental response in low frequency repetitive nerve stimulation is wrong statement, right? Incremental response in high frequency repetitive nerve stimulation test, that is what we do for Lambert-Eaton myasthenic syndrome, okay? But with low frequency repetitive nerve stimulation in Lambert-Eaton myasthenic syndrome, you have to understand that there will be decremental response. You have to understand that there will be decremental response. Now let me try to discuss the differences between myasthenia and Lambert-Eaton myasthenic syndrome. So myasthenia, it is a postsynaptic nerve terminal disorder. Lambert-Eaton myasthenic syndrome, it is a presynaptic nerve terminal disorder. And in myasthenia, the antibodies are formed against the acetylcholine receptors which are present on postsynaptic nerve terminal. Whereas in Lambert-Eaton, the antibodies are formed against the voltage-gated calcium channels which are present on the presynaptic nerve terminal, and thereby there is no release of the acetylcholine. And if you take the muscle involvement, in myasthenia, ocular muscles are most commonly involved, then followed by that the proximal muscles are involved. Whereas in Lambert-Eaton, it is the proximal muscles most commonly involved, then followed by that the ocular muscles. And the deep tendon reflexes, they are intact in patients with myasthenia, but in Lambert-Eaton myasthenic syndrome, remember, they are depressed or absent. And in myasthenia, you don't have any autonomic changes, but in Lambert-Eaton myasthenic syndrome, you have autonomic changes, and these autonomic changes will be in the form of dry mouth and as well as the impotency. And how will you diagnose myasthenia? The single fiber electromyography, it is the one which is having highest sensitivity. Whereas Lambert-Eaton myasthenic syndrome, you will have incremental response on high frequency repetitive nerve stimulation test. That is the investigation in case of Lambert-Eaton myasthenic syndrome. And if you see the tumor, myasthenia gravis, usually they are associated with thymomas, whereas Lambert-Eaton myasthenic syndrome, usually they are associated with oat cell carcinoma, which is nothing but small cell carcinoma. And what is the drug of choice for the Lambert-Eaton myasthenic syndrome? That is 3,4-diaminopyrimidine. That will increase the acetylcholine release from the presynaptic nerve terminal. That is a drug of choice in patients with Lambert-Eaton myasthenic syndrome. So this completes the discussion of the questions of the quiz which I have posted on 20th of May on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. Thank you very much. See you in the tomorrow's session.